Hello everyone, this is Dr. Jerry Vobro. The topic for this week's healthcare lecture is examining how healthcare is delivered across the globe. There will be times that you are required to pause this video and click the links in your lecture guide to find some information on your own. Please have your lecture guide open as you will be answering some questions. The answers to these questions will then be entered into D2L under the quiz for this week. You will complete the quiz at the end of the lecture, but collect the answers as you go. During this course, we are taking an in-depth look at the current pandemic, COVID-19. We will attempt to answer which system possibly has a better handle on the virus, what countries seem to be recovering, and if their system may have contributed to a more organized plan in managing the virus. The political landscape in these countries contributes to how their individual healthcare systems are regulated and monitored. We will try to gain a perspective as to who manages the country's health, who pays for the healthcare costs, and are these systems based on a profit or a nonprofit structure? Meaning, who benefits the most from the system? We will then conclude with an in-depth look at the United States system. This section should be particularly interesting to you as it'll give you an idea and some perspective as to how your own personal health care is paid for. The way that healthcare is delivered across the globe can be very different from country to country. Many models have been implemented, but they usually take on part, if not all, of an established system that works for another country. There are four main types of systems. Some countries combine them to make it work for their own situations. There are currently 197 countries on our planet, and 196 of them have some form of a healthcare system. However, not all healthcare systems are created equal. From highly regulated healthcare systems to local, shaman-dependent villages, there are diverse approaches to providing and handling health care. At this time, please pause the lecture and ensure you have your lecture guide open with the links. As I stated earlier, there are four types of defined healthcare systems across the globe. The first is the Beveridge, then the Bismarck, the National Health Insurance Model, and an out-of-pocket model. The first one we will examine is the Beveridge model. The Beveridge model was created in 1948 by William Beveridge. He was an economist and a social reformer whose ideas led to the creation of the Great Britain's National Health Service, the NHS. Beveridge's data was to provide high-quality medical care for every citizen in Great Britain. He did not believe that health care should be for profit. His timing for this concept came right after the emotional and financial turmoil of World War II. The public was very eager and accepting of his ideas. The Beveridge model is a nationalized healthcare system. The nationalized healthcare service is controlled by the government and is financed with tax dollars, the same way police, fire, and libraries are funded. Citizens of countries who utilize this healthcare plan do not directly pay for their medical care or other health-related bills. The goal of this plan is to provide quality health care regardless of people's ability to care and pay for their care. What's interesting about this model is that the majority of hospitals and their staff are considered government employees. There are private doctors and clinics, but they also receive their payment for services from the government. Citizens do not receive bills. All of their health care expenses are covered. According to the Physicians for a National Health Program, known as PNHP, this healthcare system is regulated to have more reasonable costs because the government determines what doctors can do and what they can charge for their services. There are many countries that use this system besides Great Britain. Spain, Italy, Scandinavia, Finland, New Zealand, Hong Kong, and Cuba also use this type of system. However, each country has built upon and adopted its own form of the Beveridge model. Here in the United States, two groups use this model. The Native Americans, their Indian Healthcare Service uses this, And our VA system, so our veterans system, uses this as well. You're probably wondering, what are the pros and cons? The pros of this is that every citizen has access to health care because of the universal coverage. So there aren't people who are left out in the cold getting big bills at the end of the day. Everybody is covered if they live in this system. The government is responsible for quality of care, and this may be beneficial if the government keeps the cost of health care low. Citizens also do not receive and are not responsible for medical bills or copays. I want you to give a little bit of thought about a system that is run by our government. Pick any system that's run by our government, and then just reflect a few seconds in your head. Is this run well? Is this not run well? This is what the Beveridge model is based upon, the government actually managing the entire healthcare system for the entire country. So of course that's going to come with some cons. A con of this is that every citizen must pay higher taxes, whether they use the healthcare system or not. So everybody's paying equally into this system. Also, the government is responsible for the quality of care. And this could be really harmful if the government restricts the services patients are allowed to access. In many of these countries, there are long waiting lists to receive care, and especially people who are not in non-emergency situations may wait a long time to have their care begun, such as even cancer. There may be a waiting list to get the therapies and the treatment that is needed due to a long waiting list. It is now time to pause your presentation and click on the first link on your lecture guide. That will take you to an article, and you are to read the article in its entirety and then answer the question that is on your guide. When you have finished, you may resume the presentation. Welcome back. We're now going to explore the Bismarck model. The Bismarck model is named after the Prussian Chancellor Otto von Bismarck. He developed this healthcare model in 1883 as a welfare measure to promote German unification. He based his model on 3 principles. 1, the government is responsible for universal access to health care. 2, health policy is implemented by the smallest political and administrative units in society. And 3, elected government officials negotiate the terms of medical care and reflect the interest of different medical professions. The Bismarck model is an insurance system that is financed jointly by employers and employees through payroll taxes that they named sickness funds. These sickness funds are directly deducted from paychecks. Germany is touted as the best healthcare system in the world, and they utilize this model. Does this model sound a little bit familiar? It should, because the United States has adopted a form of the Bismarck model of healthcare. Most Americans who are employed but not yet eligible for Medicare, and again, Medicare is for people over the age of 65, and Medicaid is also part of that for those who are permanently disabled, will receive their insurance coverage from their employers as a benefit of employment. However, the American version of the Bismarck is very different in many ways. The German version allows the residents to choose any carrier or provider they would like, meaning they are not limited as to who they use. In the United States, the employers limit the list of health insurers that employees can use. What's interesting that is in Germany, the employees have the option of choosing from over 200 types of sickness funds to pay into, whereas most companies in the United States have very limited choices, if any, to choose between. We even have people who work in healthcare being forced to use the system they work in exclusively. Although countries who employ this model are home to mostly private hospitals and physicians, the Bismarck model is designed for every citizen to be covered and does not aim to make a profit. Private insurance companies, which are required to be nonprofit, exist for self-employed citizens and those who wish to receive elective services not covered by a sickness fund. This financial implementation makes the Bismarck model a multi-payer system. However, these insurance companies are also heavily regulated by the government. The fact that insurance companies are nonprofit and heavily regulated in addition to fixed price procedures, controls the cost and keeps costs low for everyone. In Germany, patients have the ability to choose low-cost drugs at no personal cost or pay the difference if they choose a higher-cost drug. This allows the patients to control which medications they wish to purchase, but creates competition in the drug industry and keeps the cost of all drugs affordable. The price of procedures are negotiated between state representatives and medical associations to make sure that the price of procedures and medications are the same throughout the country. Other countries that have adopted forms of the Bismarck model include Japan, Switzerland, France, Belgium, and the Netherlands. And quite a few areas in Latin America are also under this plan. What are the pros? Individuals do not need to worry about being uninsured or going broke from expensive health care bills. Compared to the U.S., the administrative costs of this model are much lower. There is little waiting time to receive primary care services. There are cons, however. The focus on low cost and efficient care means there are less health care services available for citizens living in a rural area. Mandatory employment taxes are high in order to keep health care affordable. And there are longer waiting times for patients to receive elective secondary and tertiary services. It is time again to pause the presentation and click on the link in your lecture guide. Read the article and answer the questions on your guide, and then you may resume the presentation. We will now talk about the National Health Insurance Model. The National Health Insurance Model of healthcare is a combination of both the Bismarck and the Beveridge models. This model allows for privatized practices like the Bismarck, but is paid for by the government model of the Beveridge system. This model attempts to take the best practices from both to create a better healthcare system. The good news is that the government is usually able to keep costs low for patients, but the bad news is that the government also controls what and which medical procedures they will pay for. Also, individuals can end up waiting a long time to be treated. This model saves on expenses in many ways. One way this model keeps costs lower is that there's no need for marketing. The system is not for profit, so there isn't a financial motive to deny claims. These universal insurance programs tend to be cheaper and much simpler to administrate than our American-style for-profit insurance. The single payer tends to have considerable market power to negotiate for lower prices. The classic NHI system is found in Canada and other countries such as Taiwan and South Korea. One glaring positive result of this model is the ability to negotiate with the drug companies. Canada has negotiated such low prices from pharmaceutical companies that Americans have quit using their own drugstores and they buy pills north of the border. A big negative, however, of these national health insurance plans to control costs by limiting the medical services they will pay for, or make patients wait for a very long time to begin treatment. Again, it is now time to pause this presentation and click the link on your lecture guide. Read the article and answer the question. Then you may resume the presentation. The out-of-pocket model is a type of healthcare model that is prevalent in third world countries. In many of these developing countries, the infrastructure is not adequate to protect its citizens and provide access to medical care. Due to these shortfalls, healthcare is provided in the form of private out-of-pocket spending. For the consumer, this means there isn't any regulations of cost, and it makes these costs much, much higher. Countries that do not have established national healthcare systems make up the majority of the world. Countries that do not have some organization for medical care are usually too poor or too disorganized to provide health care for their citizens. In these situations, those who are rich and powerful are available to receive care. Those who are too poor must rely on local or untrained health care providers. In third world countries, the rural areas such as South America, Africa, and Asia, many people go without receiving care from doctors. The villagers rely on home remedies to fight against sickness and diseases. The World Health Organization, also we refer to it as WHO, stated that formal health insurance in developing countries is rare, and the cost of health care and receiving care falls directly on the citizens themselves. So essentially, if a family doesn't have the financial means to see a trained medical professional, they don't receive any care. Many of these places have village healers that are paid in labor, produce, or favors in exchange for traditional medication. The out-of-pocket model is the most disorganized system of healthcare. This model cannot ensure that every citizen has access to healthcare, and the people are often left in sickness or incur a huge debt because they cannot afford to pay for medical care. The countries that rely on this archaic out-of-pocket model are in areas that need public health reform in order to help them function. Again, please pause and click the link on your lecture guide. Read the article and answer the questions there. Then resume the presentation when you've completed that. We are now going to talk about the U.S. healthcare model. Our system in this country is a very complex mix of public and private programs. Most Americans who have health care insurance have an employer-sponsored plan. Besides the employee-sponsored plans, our government provides insurance for many of our population. You most likely have heard of Medicaid and Medicare. And just as a refresher for you, Medicaid is insurance for the poor or disabled, and Medicare insures the elderly. The federal government also insures government employees and our veterans. Each individual state run their own programs that cover their public employees. As I said earlier, the majority of the population in the United States is covered by employer-sponsored plans. These plans are private programs that the individual employer chooses. The employer selects what they want covered, how much they will pay, what drugs they will allow, and sometimes gives the employee options for copays, deductibles, and out-of-pocket expenses, which results in how much the employee contributes monthly to their specific plan. Traditionally, many of these programs have been a fee-for-service insurance, but over the past few decades, there has been a shift to managed care plans as the costs have skyrocketed and the employers try to reduce their costs. There are four main types of health insurance plans in the United States. The type of managed plan you have will dictate how you obtain your medical services. The main types of the network health plans include an HMO, which is a health maintenance organization, a PPO, which is a preferred provider organization, a point of service, states what it says, and an EPO, which is an exclusive provider organization. So how do the HMO, PPO, POS, and EPOs lower healthcare costs? Managed healthcare plans are a cost-efficient alternative to traditional fee-for-service because they share the medical costs, financial risks between their members, their insurance plans, and members of the managed care network. Since 1973, when managed care plans became available to most Americans, their popularity has grown. By the late 80s, they became one of the most popular health insurance coverage plans in the United States. Managed care plans differ from traditional plans in that the members usually must select a primary care physician from a network, and those doctors provide care for that individual. That doctor then manages the patient's health by directing the patient to specialty services that are accessed through the network. The rates for services are set, which reduce the costs of the plan. The managed care plans provide benefits to both plan members and employers in three ways. 1. Managed health care plan members benefit from reduced rates and guaranteed access to health care services. 2. Members of the healthcare network benefit from having a steady stream of clients. And 3. Plan members have an easier time because when they work with providers in a network, they avoid having to file paperwork since the network members and medical service providers have billing systems in place. The HMO plan makes this the easiest. So what is an HMO? An HMO, which stands for Health Maintenance Organizations, provides employers or groups a way to take care of all their employees or members' health care needs with reduced costs by negotiating with specific doctors, hospitals, and clinics. The employee must use these specific providers for the reduced fees to be provided to their medical insurance plan. In an HMO, you have the least flexibility, but will likely have the easiest claims experiences since the network takes care of putting in the claims for you. It is the least flexible, however. All right, a PPO is a preferred provider organization. This offers reduced costs to members billed to their health insurance plan. Like an HMO, the employees or members can choose the physician they want to see instead of being solely restricted to an HMO provider. The member can choose between a member or a non-member provider. So how this works is you enter into a PPO. It's not specific to one healthcare organization. In Milwaukee here we have Aurora, we have the Medical College in Freighter, we have Ascension, those types of plans. In an HMO, you would be limited to just one of those organizations. In a PPO, you can go back and forth between organizations as long as the provider is part of your provider network. In a PPO, which is a point of service plan, you're not as restricted as you would be as an HMO. Moving forward to the POS, which is a point of service plan, members can choose their physician that has previously agreed to provide services at a discounted fee. In a POS, the member uses the chosen physician as a gateway before moving on to a specialist. However, the employee has a medical issue, the POS physician must be contacted first in order to make a referral to get benefits from the plan. The difference is the POS is very similar to the HMO where everything is based on referrals. In the PPO, it's in many cases a referral is not needed to see a specific specialist. So you can go outside of a plan. Now those services a specialist would provide need to be approved by the insurance company, but they don't filter through a primary care physician. All right, and then the last one, an exclusive provider network or EPO has the employee or member of the plan choose the providers within the network, but they don't have to work within a primary care physician. So any service taken outside of the network may not be covered at all. All right, that wraps up the lecture portion for this week. You're going to need to pause or end the video right now, read the article in the link provided, and then answers questions 4 through 6 on your guide. You can resume the presentation after that. If you chose to resume the presentation, you will see that we have now concluded for this week. You're going to now proceed to D2L to complete the quiz. You will need to score 100% on the quiz in order to get credit for it. So you'll be allowed to take the quiz multiple times. If you've been following along with your reading guide, you shouldn't have any problem getting 100% the first time. I also encourage you all to not share answers with your peers. This is for your benefit, and everything that we talked about this week will be expanded upon in your discussion. Have a great week. And as always, if you have questions, please email me. Thank you.